Good afternoon, everyone. My name's Kevin Bazaz, for people who don't know who I am, and I'm one of the critical care pharmacists that works here at UHL, mainly at the LRI intensive care unit. And this is going to be a relatively short talk on status epilepticus and the current pharmacological treatments that we use in the trust. So I'll just go through quick through. There's going to be just a little quiz at the start of this, which I'll click onto in a second, and then we'll go through summary of the current management, talk a lot about the clinical trial that has been, depending who you read or listen to, practice changing. That's the ESIT trial from a few years ago. Focus a bit more on the commonly used agents, a brief look at the refractory options that we have, and at the end, just looking at how we built nerve center emeds to help with all of this. So I'm just going to come out of this now and then see if this works. So if you're able to go onto that QR code, it should open a link into this little 4-question quiz. So if anyone's in the teaching rooms or at home, has a go on that QR code, and it should give you a list of 4 questions, and you can just run through those questions yourselves and submit your responses. So I'll give you all a few minutes to do that. I'll talk through the questions as well, but they should come up on your phone automatically, all 4, when you click through each answer. So the first question is, what is the preferred second-line agent at UHL for convulsive status epilepticus following initial management with IV benzodiazepines? So there's 4 options: phenytoin, levetiracetam, phenobarbital, or sodium valproate. And then the next question is, what is the initial recommended loading dose for levetiracetam when used in the initial management of status epilepticus for a 90-kilo patient? So there's a few options there. See if you can figure out what the right answer is. The third question is, in which circumstance would sodium valproate, when being used as initial agent, be appropriate? So which of these is it appropriate? So you've got pregnancy, concurrent meropenem, acute liver failure, or CKD. And the final question was, which of these statements regarding IV phenytoin is true? So you reduce the dose in AKI, it's highly protein bound, first level 12 hours post-load, all of the above. So I'll see if I can go back to an initial part and see how many responses we've had. Okay. So a very clear consensus for levetiracetam as the second-line agent. Some different opinions of doses. Majority gone with 4.5 grams. A lot of variation here. So we'll look through into this as we go through the presentation. And hopefully by the end of it, you'll know which is the correct answer. And again, a lot of variation here. So again, we'll go through this when we go through the presentation. So we'll come back to this at the end. So hopefully we'll be able to figure out exactly where we are with our knowledge. Fantastic. So for those of you who haven't seen this guideline, it's been on Insight or UHL Connect now for, I think, just under a year. And it's been adapted from the ED guideline. As an adult initial management. And it's got a relatively nice flowchart to follow, which begins with benzodiazepines as is standard practice, and depending on the routes available, which then filters down to using a second-line agent. And looking at those, it mentions levetiracetam, sodium valproate, and phenytoin. And what it says there in the statement is that they all work equally as well with different side effect profiles. So that's a statement I want you to remember, and we'll come back to that a little bit later on. And then it filters down again and talks about using an alternative second-line agent. And it says that's usually phenytoin. So that's on the assumption the whatever you use first time around hasn't worked. And then we look into refractory status epilepticus, and that's usually when intensive care get called, and you're looking at much. Side, that's an excerpt from the guideline. So it says there now, phenytoin has now been replaced by levetiracetam as the preferred second-line anti-seizure medication, while a major study in 2019 found that phenytoin, sodium valproate, and levetiracetam were equally as effective to control status epilepticus. But it is important to remember this is off-label, so it's not licensed. If you look in the BNF or the SPC, it won't show you that levetiracetam should be used for status epilepticus. But the NICE 2022 guidelines recognize that using this drug, it might be quicker to administer for the nurses and potentially have fewer adverse effects than either phenytoin or sodium valproate. So at the appendix in that guideline, Appendix B, it's got quite a nice dosing table, which gives you some doses to use for levetiracetam, sodium valproate, at greater than 74 kilos, which is quite unusual for most medications to have a relatively low weight cap. And you'll see why when we go through where that weight caps come from. The yellow boxes give you some good caution and contraindication information, which might limit where you can use any of these medications. They've got lots of caveats across the board. And it also tells you about dilution and administration rates, which is useful to nurses. But again, you'll see at the end how this has been built into nerve center to make it a bit easier. So where does this all come from? So generally, phenytoin used to be our go-to drug for status epilepticus. It's only recently we've had these new agents all come on board. And a lot of that has come from the ESSET trial, which is Established Status Epilepticus Treatment Trial. And this trial asked the question, in patients with SE who had already been treated with benzodiazepines, when seizures have lasted greater than 5 minutes, which one of these three agents was more likely to lead to an absence of seizure and improved responsiveness at 60 minutes? And this came from the back of the pediatric trials, Concept and Eclipse, where they compared levetiracetam to phenytoin as second-line treatment. And that reported levetiracetam to be non-inferior to phenytoin. So the original question of those studies was to see if levetiracetam was superior, and it wasn't found to be superior, only non-inferior. So that was the baseline for this expansion into adult practice to see if the same or similar results would be found. So the ESSET was a randomized controlled trial. It was double-blinded, 57 emergency departments across the USA, and these were mixed EDs, and then randomized 384 patients. There's quite a lot of exclusion criteria, so it's worthwhile bearing in mind when we look at the evidence base about arrest, pregnancy, those who were already intubated when they arrived, they were all excluded. The patient population across all treatment arms, so we delve into the study, is quite interesting. So 70% of patients had epilepsy, which is not surprising given that we're treating seizures, but the maintenance therapy wasn't taken into consideration when they were enrolled. It was essentially ignored. So if a patient was on valproate, they could be given valproate as their rescue drug. Or if a patient was on levetiracetam, they could be enrolled onto the levetiracetam arm as a rescue drug, which is not what you would routinely do. Usually you might assume they have good compliance and they're failed, and you might want to give them a different agent if you're reviewing these patients. So that wasn't taken into consideration. One of the other bits that's worth noting from the trial is a wide age range. So this was they were all mixed EDs. So it was from 2 years old onwards, and 40% of patients enrolled were between 2 and 20 years old. So you've got to think about how the age group of those patients and how that might affect the results when we're looking at adult practice only here. There were a few other caveats from this trial that's worth bearing in mind. There was large variation in the amount of patients who got benzodiazepines before they even arrived to the ED. So 50% of patients didn't receive any benzodiazepine before they got to ED, whereas half did. So there's large variation of pre-hospital benzodiazepine dosing. And there's also a relatively large variation in the amount of benzodiazepine that was given to patients when they were in ED. The total median dose was 5 milligrams of lorazepam, all equivalent. And most of the views when I read into reports of this trial imply that probably didn't reflect real world practice in the USA, and most patients would usually get higher doses of benzodiazepine initially. One of the other things that's worth bearing in mind is how they how they address their end goal here, they improve responsiveness. That was all done subjectively by the treating physician. So they didn't use any EEG monitoring. It was all done on visual observations of like tonic-clonic movements, rhythmic eye movements. Probably might not have been realistic to have EEG monitoring for all these patients to assess their responsiveness, but it's worth bearing in mind that it was subjective in its outcome. So this is what it found. So out of 384 patients, absence of clinically evident seizures and improved responsiveness at 60 minutes, no significant differences in rates of seizure cessation or in safety. And if you look, 47%, 45%, 46% across the three agents. So essentially the same. So no difference. But what's bearing in mind here is what 50% of patients were still seizing at 60 minutes. And that's probably the big standout from this trial. Is half of the patients hadn't had their seizures resolved. And when you look at the trial itself, a lot of the patients had already been seizing for an hour before they even received these medications from the moment they arrived into their emergency department. So as many patients had almost 2 hours of no seizure control, which is a bit of a concern when the evidence is generally to try to get control of seizures as quickly as possible. The other thing to think about is the dose capping. So you can see 60 milligram per kilo, 40 milligram per kilo for levetiracetam and valproate, and 20 milligram per kilo phosphoenatoin. Now, the reason these doses were created this way was to make sure the volume of drug being drawn up and given was the same across the board, so it could be blinded, and there weren't any variations in dilution or volume and rates of administration. The problem with that is phosphoenatoin, when you limit the rate of administration at 10 minutes, you limit its dose. So phosphoenatoin's dose, you can go up to 1.8 grams, 2 grams, and the dose they were capped at was 1.5 because of the rate of administration. So there's an argument here that they were giving suboptimal phosphoenatoin dosing to all these patients, and they were giving much higher doses of what you would normally use for the other two agents. The licensed doses are much lower for these, so these super loads that we were given, which is from previous trials that had been studied, may have biased the trial to supporting levetiracetam and valproate over phosphoenatoin. So it's worth bearing that in mind. Levetiracetam, out of interest, has a very large therapeutic window. You can give 5 grams relatively safely, whereas the other two drugs, being protein bound, have a much narrower therapeutic window. So you wouldn't be as brave as accelerating the dose of those, but there are some studies saying that an even bigger dose of levetiracetam might have showed a superiority benefit in this type of. There isn't enough evidence out there yet to show which dose you should be given, which is again another problem with all these trials. There's not enough research in knowing exactly what type of loading dose is the optimal one to be given. So, in summary from all that, we know that from the patients enrolled, 53% did not achieve the primary outcome. And it's also interesting to note that of the ones that didn't achieve the primary outcome of seizure cessation, 70% of those needed further additional anticonvulsive medicines. So that caused all those patients to be unblinded, because understandably the treating physicians wanted to know what they'd already given that had failed, so they wanted to give something different. So all those patients then became unblinded at that point. Secondary outcomes, so no differences in ICU admission rates and no differences in ADRs, but there was a higher rate of hypertension and intubation with phosphoenatoin, which you'd probably expect if you look through its side effect profile. The trial was actually stopped early after reaching a predetermined review by the safety committee due to the futility of continuing. There was less than a 1% chance that if you carried on the study anymore, that it would show any difference between any of the agents. So then they deemed that to show the study showed that they were all equally safe and effective. I've mentioned the unblinding already, and that the EEG was not used to determine primary outcome of seizure cessation, and talks about how the doses of the medications shown may have been not necessarily the most optimal doses to have used for this type of study. So, I mean, for me, the biggest take-home message from this study is that 40% of patients in all groups continued to seize after an hour after administration of the study drug, and the median duration of seizure at enrollment was about 1 hour. So 40% of the patients were seizing on average for over 2 hours. So it's worth bearing that in mind when we think about this being a practice-changing study, that when you look into it a little bit deeper, there were a lot of patients who didn't achieve control of their status epilepticus. So this is what's resulted in changing our local practice and lots of local practices across the country when you look at local guidelines. So we're not an outlier on this at all. If we go into a little bit more about the drugs, and then we'll come back to that study towards the end of the presentation. So levetiracetam, as I've already mentioned, is not licensed for this indication. So if you look at the BNF and SPC, you won't find the appropriate dosing information. The load is 60 milligram per kilo, and it's capped at 4.5 grams. So that's why the weight correlates to 75 kilos if used over 10 minutes, which again is a much faster rate than what it states in the SBC and in Medusa. Maintenance doses. So this study didn't look at maintenance doses. No studies looked at maintenance doses for in critical care use. So we really don't know what the right maintenance dose is to be given. But generally, we tend to start about 1 gram BD, 1.5 gram BD. But there isn't any evidence to show that's the right thing to do. It's renally cleared. So in AKI greater than 2, there's a consideration you might want to use lower maintenance doses. And in any augmented renal clearance, then you should maybe think about doing 8-hourly frequency, particularly on patients who are continuing to have seizure activity. No dose changes required in filter. Extremes of body weight, use ideal body weight. So good bioavailability. So switch to oral when you're able to. One of the main advantages of levetiracetam versus the other agents is its drug-drug interactions. Relatively limited, and with commonly used agents in critical care, few and far between. Safety information, there's a few things to be wary of, particularly the psychotic symptoms and behavioral issues you might get. So just think about the patient cohort we're using this in. But apart from that, the rest is relatively clean with a side effect profile. Sodium valproate, on the other hand, is very different. So again, not licensed, same as levetiracetam. Its loading dose is a little bit lower, 40 milligram per kilo to a max of 3 grams, given just as quickly. The maintenance dose, generally anything between 800 milligrams to 2,400 milligrams in a day, split BD or TDS. IV vials come in 400 milligrams, so it's useful to round that dose to 400 just to make your nurse's life a bit easier. No doses usually required in filtration or AKI, but with liver impairment, there is a significant risk. So it's contraindicated in active liver disease and in history of severe hepatic dysfunction due to the risk of accumulation toxicity, particularly in disease states that are associated with decreased protein binding. It's a very high protein bound drug. Toxicity is very difficult to assess. It doesn't correlate with anti-epileptic activity. So generally you only take levels to check for compliance or if someone's coming in an overdose. Otherwise, they're not very useful. Again, bioavailability is good. So if we're able to, you can switch to the liquid for NG or oral if the patient's able to take oral tablets. There are many drug-drug interactions. I'm not going to go through any of them here because this will be the whole presentation. But the main one for everyone here to be aware of is meropenem. So some of you know this and you might not. But meropenem, for an unknown interacting mechanism, can reduce serum valproate levels by up to 90% within 24 hours. So if you have a patient you're acutely trying to manage or has got baseline medication that's sodium valproate and use meropenem, you have to assume you've got virtually no valproate left. Not every patient responds this way. In the studies that have been taken, some reduced by 20%, some reduced by 50%, but you won't be able to measure that. So you have to assume the worst case scenario and recognize that this risk will exist if you use carbapenems. If you have to use meropenem, then you need to give a secondary agent alongside to manage this interaction. Usually that's levetiracetam, and there's a separate guideline that's on our UHL Connect that guides you about how much levetiracetam to give and how long to give it for. You normally have to use it for at least 2 weeks after you stop the meropenem to minimize any seizures breaking through. It's very hepatotoxic, has dose-related thrombocytopenia, hyperammonemia, pancreatitis. Switching between different forms can be tricky sometimes, especially when you've got modified release patients coming on and you have to switch to immediate release for ICU patients. So there's a lot more caveats using this drug. And not only that, but there's this, which I'm sure most of you will know about now, but it keeps on developing. So there's significant risk of valproate in women. It's highly teratogenic. And this year, January 24, for all of valproate, there was a national alert that it should not be started any new patients, younger than 55, male or female, unless 2 specialists, and that's usually neurology specialists, consider and document that there's no other effective treatment. Further to that, there's risks in men now, which have come through, so risk in infertility. And then more so, recently in September this year, there was risks that men using it may actually lead to some neurodevelopment problems with children, so extra precautions of contraception to be used. And again, another agent, topiramate, has also been introduced into the pregnancy prevention program, which is not as often used for epilepsy these days, but it can be used occasionally, and it is also used in mood disorders and for migraine prophylaxis. So another drug to think about. But it's worth bearing in mind that, as far as I'm aware, no one's really developed a way of managing these risks for our acute use in status epilepticus in critical care. I don't know how often we routinely check pregnancy before we start this drug in women, and particularly in men. No one knows whether the adverse effects are dose-related. Studies were done in chronic use, but we don't know if using it for 2-3 weeks in an inpatient in a male who then gets discharged later, should we be giving counselling advice? None of that's really been considered because this is all relatively new. So it may change, but it's worth bearing in mind. This drug in particular has lots of additional risks that the other drugs don't have. And finally, phenytoin, which I think many ED departments are delighted that we're no longer going to be using a first line, and you'll see why. So this is licensed, and it's got a 20 milligram per kilo IV loading dose with a max 2 grams. But one of the most important things is giving this drug slowly. So they're the maximum rates and a bit lower in elderly cardiac disease patients because it can cause severe hypertension, arrhythmias, CNS depression. If you give it more quickly, you give it too quickly. So you should have cardiac monitoring. And then if you notice some of these effects occurring, you might need to lower the infusion rate even more. Not ideal to be given peripherally. You can get some really horrible exposition. So CVC is optimal, but that isn't always possible in ED. So it can be difficult to give this safely in an ED environment. The maintenance dose is generally 100 milligrams IV PO every 6 to 8 hours. It's okay in renal impairment, although in ECMO, because of protein binding, you generally need to have more frequent TDM to make sure you optimize the dose. And the protein binding is one of the big issues here. So again, increased risk of accumulation and toxicity with any disease states that have decreased protein binding. Extreme body weight, you need to use ideal body weight or dose determining body weight. Bioavailability is okay in healthy patients. But again, enteral feeds into phenytoin. So if you're going to give it enterally, you'll have to stop the feed 2 hours before and 2 hours afterwards. The liquid requires a dose conversion from the oral, so it's a little bit messy. And because it's a post-an enzyme inducer, it interacts with lots of other medications, including other seizure medications. So again, it has lots of issues. And so using it empirically, you can see why it's not the nicest agent. It needs TDM monitoring. Those are the levels that you would normally look for. So therapeutics 10 to 20. It has nonlinear pharmacokinetics, saturable metabolism. So small changes in phenytoin doses are not proportional to the result that you want. You may get large unexpected changes in plasma concentration of phenytoin. The free drug is a form of active form, which we can't measure easily. So we have to use the total phenytoin for levels, and that's what we normally tend to do. But they have to be corrected for low albumin, for uremia, via a relatively complex equation. So it's not something we do as often these days because you don't use this drug as often. You have to repeat your levels. Again, there's no point doing it early because your loading dose is not going to give you any valuable information. The first dose really just tells you if you're not giving too much. It takes at least 2-3 days to get to steady state, and after that, you can probably repeat it every 3 days, and then sometimes every 7 days if your patient's relatively stable. But it requires a lot more work to make sure you're optimizing the dose of using this agent. And then obviously you have toxicity if you give too much. And these are some of the side effects. So I'm sure you're familiar with some of these already. And this talks about the free phenytoin levels. This would be much more accurate and would get rid of the albumin issue. But I think maybe 1 or 2 hospitals in the country are able to do this. It's very expensive. We certainly can't. And given the fact that most places aren't using this drug very frequently anymore, I don't imagine many places will continue giving free phenytoin levels. So we'll have to keep correcting for albumin, unfortunately. Briefly, just looking at some refractory options. I'm going to these in too much detail. So you've got the anesthetic agents, thiopentol, propofol, midazolam, ketamine. You've got some additional anti-seizure medications, which I think we have seen more and more being recommended in neurology when our original agents fail. So things like lacosamide, phenobarbital. And there are some immune therapies that can be used. Now, I know the Royal are going to be getting some CAR T-cell patients through soon, and they actually have some neurological toxicity side effects, that therapy, and we might be seeing them, and it's classed as ICANS, if you haven't heard of it. And that's characterized by having early manifestations of tremor, expressive dysphagia, and that can rapidly progress to seizures and cerebral edema. So in the guideline for ICANS, they have noted that anakinra and tocilizumab and rituximab can be used to mitigate the seizures that a patient might be having. So those immune therapies might be something we see more often at the Royal when these patients are coming through to us. So sort of bearing in mind that these options do exist, but we wouldn't normally use them empirically, normally in conjunction with neurology input. So we just go back through to what we've seen on nerve center. So what's been built, and this mimics what's in the ED, is the weight banded dosing. So not only does this make it relatively easy to prescribe the loading dose, it also means it's relatively easy for nurses to give it, especially in an emergency situation. If you did milligram per kilo dosing, you would get some awkward numbers for nurses to dilute into. And what we don't want is delays in these drugs being given. So we try to keep it simple, try to keep it easy for nurses to give. So levetiracetam, valproate, and phenytoin all have loading doses, and you can find them in the adult ICU folders. If you go down to the seizure section, you'll see them all listed in there. And the maintenance doses are below if you want to carry them on in ICU. So in summary, and this is when it gets a bit interesting, you can look at it 2 ways. So if you're optimistic, you might say that all these options are 50% successful, but maybe some should be initiated sooner, maybe at the time of the second benzodiazepine dose to shorten the duration of seizures. The non-inferiority across the 3 agents should allow us to move away from phenytoin use. Phenytoin is a tricky agent to optimize, a tricky agent to continue with. So if all these drugs work equally as well, there isn't really an argument to carry on using phenytoin, even though it is licensed for its indication, the other 2 aren't. So that's probably the optimistic view. The pessimistic view might be that they're all equally as rubbish as each other. And with 40% of patients who carried on seizing an hour after the administration of the study medication. And there might be an argument that we might need a radical overhaul of how we manage seizure control altogether. Maybe it requires early involvement of critical care. Maybe we need to be more aggressive. Perhaps we need to use these so-called second-line agents and have them as combination first-line agents. So you have the benzodiazepine and you give it concurrently with a high-dose levetiracetam load simultaneously, and perhaps that will give you a better outcome. That hasn't been studied, so there needs to be research done to optimize the dosing of these drugs that we're using. Do we need to give more levetiracetam to give a better effect? Do we need to give it quicker, as in earlier in the stage of seizures? Do we need some more maintenance dose we're giving? Should we be giving higher maintenance doses? Valproate and levetiracetam don't have TDM that equals efficacy, so we can't monitor the effect of it like we can with phenytoin. So in my opinion, the outcome of the ESSA trial was that we don't use phenytoin anymore. I don't think we can say that levetiracetam is better. Study doesn't show that at all. You've got a slightly cleaner side effect profile, and valproate has got lots of additional issues that you'd ideally avoid if you're able to. So you can see why levetiracetam has become the first choice, but it's a first choice out of safety. I don't think it's a first choice necessarily of optimizing seizure control. And I still think we're a long way away from being able to do that. So this is just going back to the quiz at the end. So second-line agent levetiracetam. The dose for 90 kilo patient is 4.5 grams because it's capped at 75 kilos. So you wouldn't use valproate in pregnancy, you wouldn't use meropenem, you wouldn't use it in liver failure, but it's okay in CKD. And phenytoin is very highly protein bound, which causes lots of these issues with monitoring. So that's the one that is true. You don't need to just reduce dose in AKI. Target level of 30 will be toxic, so much lower than that. And taking that level 12 hours per side wouldn't be useful. So that's what we've gone through there very quickly.
It's not a very exciting journal club topic, but I'm going to try my best to make it a bit more exciting. Sorry if there's a few plot holes, because I last looked at this about a week ago before I got the lurgies. So it's all about Ghrelin use for neuroprotection in post-cardiac arrest patients. A little bit of background behind the actual study. So they wanted to look at out-of-hospital cardiac arrests and their neurological outcomes. So we're aware of lots of different neuroprotective strategies that are out there, and most of them are quite unequivocal as to whether they work or not. This particular one, they wanted to look at Ghrelin, aka the hunger hormone. So it's the one that makes your tummy grumble, and it's an excitatory neurotransmitter. And what they based this particular paper on is some experimental studies that were done on in vitro neurofunction in living rats after exposure to hypoxia. And they thought that there was improved neurological function, and they thought that it could reverse potentially apoptosis, particularly in neurodegenerative disease. The main reason that they wanted to try it was because it has a good safety profile with very few adverse effects. I think the main kind of adverse effect expectedly is tummy grumbling, which they did note in the paper. So they wanted to see, can the use of this improve neurological outcome based on these experimental studies post cardiac arrest in humans? So the design and funding, so it was a phase 2 trial, double-blind, placebo-controlled, randomized trial. It was rolled out across 3 intensive care units in the Netherlands. So importantly, they had to obtain informed consent, written informed consent before randomization. And obviously the main way for them to do that was through the next of kin of the patient. So there was a lot of fallout during the actual study. And then they also had to obtain written informed consent for follow-up from any surviving patients as well. So again, lots of fallout from the study. In terms of the funding, it was a Dutch government grant and potential conflicts of interest. So one of the in particular is a co-founder of a clinical science systems, which they basically roll out sort of like computer tech in the Netherlands, like medical computer tech. So I just thought that was kind of worthy of note. Population. So the inclusion criteria was anyone more than 18, GCS less than 8 following resuscitation for any cardiac arrest. It wasn't sort of specified or narrowed down as to whether there's specific rhythms that they're including or excluding. And then they would have to initiate the first treatment of Ghrelin within 12 hours of ROSC. Exclusion criteria was anyone with a known progressive neurological disease, and if there was someone that they were expecting death within 48 hours, which I thought was quite vague, because you may have someone who comes in is fairly moribund but has ROSC and they still kind of hang in there. So I thought that was a little bit vague. So they screened around 783 patients between 2019 and 2022, and out of the 783, around 160 were eligible and included. The median age of that population was around 68 years old, and around 75% were men. So about 119 men, 41 women. The intervention, so they randomized in a 1-to-1 ratio, and as we said, it was double-blind. The intervention group received acyl Ghrelin at a set dose of 600 micrograms, and they would give that as a twice daily bolus infusion for around 7 days. And then the placebo was just saline, again, just twice daily bolus infusion for around 7 days. And as we said, starting within sort of 12 hours of arrest. They did make a sort of important note, in addition to administering this intervention, to make sure that the basic sort of neuroprotective care was standardized. So the usual sort of temperature management, adequate MAP, adequate urine output, and if there's someone that we're querying, ACS, providing early angiography. So primary outcome, they wanted to look at the CPC scale at 6 months, and I've just put that on the right there. So it's a graded between 1 to 5. But if you look at the sort of description of each part of the scale, it's fairly on a continuum, and it's quite vague. And how they assessed this was by a telephone interview, and it could either be nursing staff or any physicians as part of the study, and they were blinded, so when they phoned, they wouldn't know what arm the patient had been on. Secondary outcomes were mortality, and then looking at the CPC score at 3 months and 12 months. The other thing that they looked at was neuron-specific NLAs levels at day 1 and day 3 post-arrest, because it's they felt it was a marker of neuronal damage, so that was an additional thing they wanted to look at. So the stats, so we've already mentioned they randomized it in a 1-to-1 manner. In terms of the sample size, I couldn't see that they'd done a power calculation before they started the study. Their comparative statistics that they used, so they used a combination of chi-squared, Mann-Whitney U-test or t-test, depending on whether they were looking at or comparing categorical outcomes or continuous outcomes. They did do like a regression analysis to adjust for any potential confounding variables. Although of note, there were certain patient demographics that they didn't collect at all. So things like race and ethnicity. So obviously those are things they didn't really adjust for. They didn't do a sort of post hoc analysis as well, just to explore for any differences that weren't planned during the study. So all in all, the stats were a little bit confusing, and I'm not entirely sure that they were that robust, if I'm honest. The results. So primary outcome, so that was the CPC at 6 months. So you used the odds ratio, and found that the odds ratio for improvement in the intervention group was 1.78. But of note, we can see within the confidence interval, your odds ratio of 1 lies within the 95% confidence interval. So although there's a trend towards improvement, it's not really statistically significant. The same can be said for the outcome at 3 months. So odds ratio of 1.22, but again, no real significant difference when you look at the confidence interval. Mortality rates. So they looked at the ARR for mortality rates and found that it was around 14%. So again, p-value of 0.08, not statistically significant. They looked at the median time to when they would potentially withdraw life-sustaining treatment. So this happened in around, it was kind of equivocal in the two groups. So 20 out of 30 deaths in the intervention group and 28 out of 39 deaths in the control group. And they found that that usually happened at around 3 days. The NSE levels that we said that we used as a sort of biomarker of neuronal damage, they measured them either sort of both day 1 and day 3 after the arrest. At day 1, they found that the values were significantly lower in the intervention group compared to the control group, mildly statistically significant. And then at day 3, there was no real difference or change in the NSE values. So again, it's something that how clinically important it is, we don't really know. It was really only at day 1 that they found the values were significantly lower. So what can we infer or make of all this? So just like we said, there was a trend towards improved neurological outcomes in the intervention group, so the group that received acyl Ghrelin. But is it really statistically significant? No. There are lots of confounding factors which I think weren't really taken into play accurately. And again, for the mortality rates, although they've mentioned it was lower in the intervention group, it never really reached significance. The reduction in the NSE levels that we said at day 1, it could suggest potentially neuroprotective effects of Ghrelin, but again, we can't really say that with any real authority because at day 3, there was no real change. And again, we've already mentioned as above, the main thing was the neurological outcomes, which we haven't seen any demonstrable change. And we don't know what the longer term clinical implication of using NSE levels are as a biomarker of damage. How will this study affect my practice? So for me personally, it's not something that's part of standardized neuroprotective care. The NSE levels is a more research-based measure. We don't know what the clinical significance is. I can't say with any certainty that I've ever seen that used anywhere outside of a research setting. So personally, I don't think it's going to affect practice. Does anyone else feel any differently? Helen, you look bored. Does anyone have any questions? Sorry, I've kind of whizzed through that a bit, but please feel free to ask away and leave feedback, of course.